I've been intensively studying the pathophysiology of COVID-19 since the start of the pandemic for the purpose of developing treatment options for my patients. Much of what I've learned and much of the science I've posted online in two videos, one on Vimeo and the other on YouTube. There are extensive references there. And if you want more detailed information than I'm able to present today, I recommend that you look there. In thinking about the web of interconnections between symptoms, pathology, and pathophysiology, I created this visual guide to try and understand that. And it is literally a web, a spider web. It's not perfect, but I haven't seen anything that does a better job. At the core of this spider web are two phenomena that are very common with COVID-19. The first is a deficit of the vital enzyme ACE2, which is induced by viral infection. I have a lot of information about ACE2 in the video that I presented to the American Nutrition Association, November of 2020, which is one of the links. One of the consequences of ACE2 deficit directly, and also of the inflammation that's created with COVID-19, is mitochondrial stress and dysfunction. Those are central phenomena. Spreading out from those are a series of pathophysiologic changes. Heading in the 12 o'clock direction is inflammation of the endothelium, endothelitis. Microthrombosis are also very common. Over towards 3 o'clock, there's mast cell activation, monocyte polarization. Now, this is a pretty complex phenomenon that involves monocytes, macrophages, and glial cells, and shifts them in both a senescent and a pro-inflammatory direction. Down at 6 o'clock are autoantibodies, and there have been large numbers of autoantibodies detected in people with COVID-19, most of which need inflammatory cofactors to be activated. Next to that, and probably one of the reasons for the massive autoantibody production, is T cell dysfunction, a very common phenomenon in COVID-19, and linked to what goes over to the left, viral persistence, which is probably the hottest new research area in long COVID at the moment. And interlinked with viral persistence and with inflammation having a life of its own is microbial dysbiosis, especially in the gut, although it likely occurs in the upper and lower respiratory tracts as well. I want to start with ACE2, which is the center really of SARS-CoV-2 infection, because ACE2 is the molecule that the virus needs to enter almost all human cells. And it is a vitally important enzyme with multi-system protective effects: cardiac, vascular, neurologic, pulmonary, renal, hematopoietic. It is anti-inflammatory, anti-thrombotic, and anti-fibrotic in its actions. In the gut, ACE2 has a special function. It is a chaperone for the transport of large neutral amino acids. So an enteric ACE2 deficit impairs, in particular, the absorption of tryptophan, which depletes serotonin and niacin, diminishes the synthesis of beta defensins, and directly produces gut bacterial and fungal dysbiosis, a common feature of COVID-19. Most of the complications of acute COVID-19 can in fact be traced to ACE2 deficiency: ARDS, cytokine storms, thromboses, cardiac and vascular disorders, dysautonomia. In fact, of the three types of POTS that have been described, one is a direct effect of ACE2 deficiency, and gastrointestinal dysfunction. So looking at the role of ACE2 deficit in long COVID, there's a direct impact in creating some of the strands of pathophysiology that go out. Endothelitis is probably the commonest. Gut microbial dysbiosis has been quite well described. Microthromboses likely owe their origin in part to ACE2 deficit. And monocyte polarization, which has received a lot of attention in a couple of settings, especially in the work of Bruce Patterson. ACE2 plays a really essential role in the normal life cycle of monocytes, which unfortunately I don't have time to go into today. Enhancement of ACE2 activity has been foundational for all of the treatments that I've used since the beginning of the pandemic for preventing severity of acute COVID, for treating acute COVID, and for preventing the development of long COVID and trying to reverse the impact of long COVID. The three most important and fundamental in my practice are vitamin D, using doses of 1,000 to 5,000 or 10,000 units a day. Curcumin, generally about 1,000 milligrams per day. Resveratrol, generally in the range of 1,200 milligrams a day. Antioxidants enhance ACE2 activity when there is inflammation and oxidative stress. Alpha lipoic acid has been shown to protect the brain and the autonomic nervous system from the impact of ACE2 deficit. And NAC also protects ACE2. Now, none of these are clinically studied. All of this is basic science research. Omega-3 oils have an indirect effect in enhancing ACE2 activity through a biochemical pathway called the apelin signaling pathway. Cannabidiol may also do it, but based on the in vitro work, a human dose would have to be at least 200 milligrams a day. There are a number of drugs that increase ACE2 activity, and some of them are already being used in attempts to treat long COVID. Statins, glucocorticoids, spironolactone, and azithromycin are the main ones that are being used, not for that purpose, but that would be a side benefit of those. Now, studies in the laboratory have shown that a deficit of ACE2 directly causes mitochondrial stress. And there are many studies indicating that mitochondrial dysfunction, stress and dysfunction occur after the end of COVID-19 and persist. We most know mitochondria because of their impact on cellular energy. About 80% of the ATP in the body is produced through mitochondria. I certainly use physical fatigue and loss of stamina and weakness as one indicator that we really need to look further at mitochondrial dysfunction. But mitochondria are very important for the functions of all tissues, the brain in particular, and also the immune system, which is heavily dependent on energy. So mitochondrial dysfunction has definitely been implicated in T cell dysfunction. And I've seen some indications that it may be related to abnormal mast cell stabilization, although that's more limited. There are a number of supplements and virtually no drugs that allow mitochondria to be rescued. Coenzyme Q10, carnitine, several of the B vitamins, D-ribose, NAD and urolithin A are especially important for respiratory complex 1 in mitochondria. And the effects of vitamin B3, either as niacin or NAD or one of the analogs of niacin like nicotinamide riboside or nicotinamide mononucleotide, they are enhanced by resveratrol and may also be enhanced by NAC or glutathione because mitochondria are really sensitive to oxidative stress. Coenzyme Q10 is definitely the supplement that has been studied the most. The dose needed is less for ubiquinol than for ubiquinone. The range is about 200 to 400 milligrams a day in divided doses. Lower doses just don't work for mitochondria. I also use idebenone, which is a CoQ analog at a dose of about 150 milligrams once or twice a day. That's been shown actually to reduce neutrophil external traps, which have been implicated in the pathophysiology of COVID-19, and to increase flow-mediated vasodilation, which is impaired even in healthy young adults after COVID-19. PQQ, or pyrroloquinone quinone, is found in a number of foods and as a supplement may also be helpful. A lot of people push vitamin C in the setting of COVID-19. I tend not to do that because of studies I've seen that ascorbic acid, usually as a mono supplement, mono treatment, actually impairs mitochondrial biogenesis in response to exercise and other types of stress. So I would really use caution with vitamin C. Okay, so we've looked at ACE2 and mitochondria and their relationship to their impact on the skeins of this web. I'm going to go out to the skeins themselves now, starting with endothelitis and microthrombosis, which are closely related to one another. That is, endothelial inflammation activates platelets. Platelet activation damages the vascular endothelium. And there's a feed-forward cycle that I think is really important. This was a great study published last year, which found that number one, SARS-CoV-2 infects megakaryocytes, and it actually alters their genome expression, creating a relative aspirin resistance and increasing the platelet release of MRP-814, which then activates endothelial cells, promotes an inflammatory hypercoagulable phenotype, and it may be blocked or responsive to P2Y12 inhibition. There's several drugs that do that. There are two natural products that I frequently use, along with a relatively high dose of aspirin, 325 milligrams a day. Dan Shen, an herb used in Chinese medicine to help circulatory function, which is a P2Y12 inhibitor, and ginkgo biloba. Dose of ginkgo is 120 milligrams twice a day. Mast cell activation may also contribute to endothelitis and thrombosis. The treatment of mast cell activation is based on blocking the release or action of mast cell mediators. We could spend a week talking about mast cell activation syndromes. The medications that are most used are histamine antagonists, H1 and H2 receptor blockers, aspirin and NSAIDs, which block the prostaglandins, PGD2 especially, leukotriene antagonists, sodium chromoglycate, which is a mast cell stabilizer, hydroxyzine, and ketotifen, in addition to being antihistamines or mast cell stabilizers, cyproheptadine, a serotonin antagonist, and steroids. And there is evidence that both H1 and H2 blockers may improve T cell function in patients with COVID-19 and also in animals and in people without COVID-19 because of the immune suppressive effects of histamine, which is the best studied mast cell mediator. So what we have here between noon and 3 p.m. is a triad that I think plays an important role and needs to be approached as a triad in patients with long-haul COVID: endothelial inflammation, microthrombosis, and mast cell activation. And it's a lot to take in. So there are natural products that will address mast cell activation by stabilizing mast cells, primarily quercetin, palmitoyl ethanolamine, luteolin, thymoquinone from black cumin seed, pycnogenol, perilla seed extract. These have all basically been studied in vitro. Question is, how many things are you going to have a patient take? So there are a number of indicators that I use to decide that we need to focus on mast cell activation. The patient has multiple hypersensitivity reactions to treatments that we've tried. They all backfire. Treatment resistance will lead me to look at mast cell activation. Fluctuating symptoms, pain that comes and goes for no particular reason, unexplained swelling, erythema, skin rashes, migraine-related phenomena, not necessarily headaches themselves, but some of the other migraine phenomena, including dizziness and signs of brainstem dysfunction. Migraines are mast cell related. They also occur when mitochondria dysfunction. Laboratory parameters, which are often lacking, but if they're present, definitely point us in that direction: elevations of plasma or urine histamine, or prostaglandins or leukotrienes, elevation of tryptase or of interleukin-13. I'm not going to say more about monocyte polarization or autoantibody production. I want to move over to what I think is the most important area in research today, which is the concept of viral persistence. There's a lot of evidence indicating that viral persistence may contribute to long COVID. And the questions are, is this live virus? Is it replicating virus? Is it just viral proteins? And the research is not clear on that. The lines of evidence on viral persistence, I just want to go back to this really interesting study from Northwestern University. Patients with neuropask were found to have impaired function of T effector memory lymphocytes. This is an immune deficit that is seen with persistent antigenic stimulation. May also, of course, contribute to the activation of latent viruses. Two studies that have shown really different phenomena that need to be reconciled. One is a very recent study, patients with inflammatory bowel disease. There were viral proteins on biopsy in the epithelium at routine colonoscopy done months after they'd recovered from COVID-19. There was no virus found in the stool. The patients who had viral proteins in their colonic epithelium were the ones who had symptoms of long COVID. And the patients who were back to their pre-COVID state of health did not have persisting viral protein. Really interesting study. There's an equally fascinating study appeared last year from Italy. I think it really needs confirmation. These scientists were able to find SARS-CoV-2 in stool. What is fascinating about this research and kind of groundbreaking is that when they did pure bacterial cultures of commensal gut bacteria from people who had had COVID-19, they were able to demonstrate the presence of replicating virus in their laboratory. The virus that was the most infected was Faecalibacterium prausnitzii, which is a keystone butyrate producer that is depleted during the course of COVID-19. They also found that antibiotic treatment could eliminate the viral RNA, and they proposed that COVID-19 can act like a bacteriophage, not just a human virus. So what we have here is a dyad of microbial dysbiosis and viral persistence that I think is an important area that I'm exploring with some of my patients who have not responded to other treatments. The impact of COVID-19 on the gut microbiome has been shown to persist for many months. And in addition to that, the gut microbiome at the onset of COVID predicts the development of PASC, long COVID. In particular, the loss of butyrate-producing bacteria, especially F. prausnitzii, showed the largest inverse correlation with PASC at 6 months. That is, the presence of these butyrate-producing bacteria showed the largest inverse correlation. It was their absence that correlated with PASC. Now, butyrate is not only important for the health of the gut, it has systemic effects and it's readily absorbed. It is a histone deacetylase inhibitor that activates the gene for brain-derived neurotrophic factor, BDNF, which you need for recovery after brain injury. It activates some G protein coupled receptors, GPR41 and 43, which are involved in regulating immune responses and inflammation. And when it comes to immune responses, T cell function seems to be particularly influenced by butyrate. So on the left side here of this web, we have a triad of microbial dysbiosis, viral persistence, and T cell dysfunction, all of which are being carefully studied, all of which can be treated and are actionable, but I think they all need to be addressed. I don't think you can just take one strand. So my program for reversing the PASC-associated dysbiosis is in flux right now. Originally, I thought a high-fiber, polyphenol-rich diet plus prebiotic oligosaccharides increased the growth of F. prausnitzii, increased butyrate secretion, that would work. The dilemma is if SARS-CoV-2 acts as a bacteriophage with F. prausnitzii as a preferred host, at what point do we want to increase its growth? Maybe only after we're sure that there's been complete eradication of the virus. So I'm presently using butyrate as a postbiotic, in part to support activity cytolytic T lymphocytes, that is the CD8 killer cells. And CTLs are critical for antiviral immunity. They are also important for vaccine-induced protection against COVID-19. Their activity is boosted not only by butyrate, but a few other things, and lactobacillus consumption through yogurt, fermented foods, or as a supplement has been shown to increase the number and activity of CTLs. I like Lactobacillus plantarum, which is found in the plant-based fermented foods. It's available as a supplement. It has been shown to reduce infection after major abdominal surgery by 70%, and to improve gut barrier function and decrease the growth of gut pathogens in patients with pancreatitis, increasing the clinical outcome. It's a pretty important probiotic. There is a type of CTL that is really important in COVID-19. These are T effector memory cells. They're cytotoxic lymphocytes that have a memory for the specific virus. They're also really important for keeping Epstein-Barr virus in check and in its latent form. They thrive on fatty acid oxidation, the availability of butyrate, and the presence of lactobacilli. There are two substances that have been shown to enhance their activity. L-carnitine is one, and I use a dose of 500 to 1,000 milligrams twice a day. And the drug fenofibrate, a PPAR agonist, has also been shown to do that. Black raspberry concentrate, possibly by increasing the yield of butyrate in the gut, is a delicious way to do it. So I thank you for your attention. I look forward to further research to expand on the use of the web of long COVID as a way of treating long COVID.